Welcome. Today we're diving into the world of piriformis syndrome, a lesser-known but impactful cause of sciatica and lower back pain. This condition, first described in 1947, involves the piriformis muscle, which can compress the sciatic nerve, leading to pain in the buttock and down the leg. Although it's not as common as disc-related sciatica, piriformis syndrome affects a significant number of people, especially those between 30 and 50 years old. In this video, we'll explore its history, how it's diagnosed, the treatments available, and what outcomes patients can expect. Let's start by understanding why this syndrome matters and who it affects. Piriformis syndrome may not be as widely recognized as other causes of sciatica, but it's more common than you might think. Sciatica itself has a lifetime incidence of 13 to 40%, and piriformis syndrome is estimated to account for up to 6% of all cases of low back pain and/or sciatica. In the United States alone, about 2.4 million people are affected each year. Both athletes and working-age adults are at risk, making this a condition that crosses many demographics. Understanding its prevalence helps highlight the importance of accurate diagnosis and effective treatment. Hallmark symptoms of piriformis syndrome include buttock pain, pain that worsens while sitting, tenderness near the greater sciatic notch, and pain during movements that stretch or stress the piriformis muscle. These symptoms can mimic those of lumbar disc disease, making diagnosis tricky. Patients often report difficulty with activities like sitting for long periods, climbing stairs, or even walking. Recognizing these patterns is crucial for clinicians to differentiate piriformis syndrome from other causes of sciatica and to guide further diagnostic steps. Thorough medical history is essential in evaluating piriformis syndrome. Many patients have a background of blunt or indirect pelvic trauma, such as falls or hip sprains, or have experienced muscle stress from vigorous physical activity or sports. In fact, 38.2% of patients in the reviewed studies had such a history. Sports like cycling, running, soccer, and gymnastics are commonly implicated. Additionally, a small percentage of patients had previous lumbar spine surgeries that failed to relieve their symptoms, highlighting the need to consider piriformis syndrome in persistent cases. Diagnosing piriformis syndrome is often challenging because its symptoms overlap with other causes of sciatica. Instrumental exams like MRI or EMG don't always reveal clear findings, and sometimes the diagnosis is made based on clinical features alone. In the systematic review, about half of the patients had their diagnosis confirmed by instrumental exams or diagnostic injections, while the other half were diagnosed clinically. This variability underscores the importance of a comprehensive approach, combining history, physical examination, and, when possible, imaging or nerve studies. Several physical examination maneuvers can help suggest piriformis syndrome. The piriformis sign, Freiberg test, Beatty test, pace test, and fair position are all used to provoke symptoms by stretching or contracting the piriformis muscle. For example, the fair position, flexion, adduction, and internal rotation of the hip, often reproduces the patient's pain. These tests, while not definitive, provide valuable clues and can guide further diagnostic workup, especially when imaging is inconclusive. Imaging studies, particularly MRI of the pelvis, play a crucial role in confirming piriformis syndrome. MRI can reveal anatomical variants, muscle hypertrophy, or masses impinging on the sciatic nerve. In the review, 29.7% of patients had their diagnosis corroborated by MRI or magnetic resonance neurography. Other modalities like CT, ultrasound, and bone scintigraphy were also used in select cases. However, nearly half of the patients had no instrumental or intraoperative findings, highlighting the limitations of imaging and the need for clinical correlation. Electrodiagnostic studies like EMG can sometimes detect sciatic nerve entrapment, especially when standard imaging is unremarkable. Diagnostic injections, where anesthetic or corticosteroid is injected into the piriformis muscle, can provide both diagnostic and therapeutic benefits. If symptoms temporarily resolve after injection, it supports the diagnosis of piriformis syndrome. In the review, a small percentage of patients were diagnosed solely based on these tests, emphasizing their value in complex cases. After treatment, the most frequent causes of piriformis syndrome identified by instrumental or intraoperative findings were anatomical variants of the piriformis muscle or sciatic nerve, 12.7%. Pyomyositis 9.4%, and muscle hypertrophy 7.5%. Other causes included scar tissue, vascular anomalies, hematoma, lipoma, and even rare conditions like endometriosis or lymphoma. Interestingly, nearly half of the patients had no clear instrumental or intraoperative findings, which further complicates the diagnostic process. Conservative or non-surgical, treatments are the first line of management for piriformis syndrome. These include local injections of anesthetics or corticosteroids, physiotherapy, exercise programs, botulinum toxin injections, dry needling, and in some cases antibiotics for infections. In the systematic review, 41.1% of patients improved with conservative therapy. These treatments are generally safe, and adverse effects were rare in the reviewed cases. Encouraging non-surgical management before considering surgery is recommended to minimize risks. When conservative treatments fail, surgery may be considered. The most common surgical procedure is the release of the piriformis tendon, sometimes accompanied by neurolysis of the sciatic nerve or removal of masses like abscesses or lipomas. In the review, 59.9% of patients underwent surgery, and the majority experienced significant improvement. However, surgery carries risks including infection, hematoma, nerve injury, and in rare cases, persistent or worsened pain. Therefore, careful patient selection and thorough diagnostic workup are essential. Overall, the prognosis for piriformis syndrome is favorable when appropriately diagnosed and managed. In the systematic review, 92.9% of patients improved or healed after therapy, with 58.9% benefiting from surgery and 41.1% from non-surgical treatments. However, 7.1% of patients did not experience pain relief, highlighting the importance of accurate diagnosis and individualized treatment plan. Surgical failures were more common in patients diagnosed clinically without instrumental confirmation. Instrumental confirmation of piriformis syndrome, such as through MRI or diagnostic injections, significantly improves treatment outcomes. In the review, patients with instrumental diagnosis had a much lower rate of surgical failure compared to those diagnosed clinically. The odds of surgical failure were 5.3 times higher in the clinical-only group. This finding emphasizes the need for thorough diagnostic evaluation before proceeding to invasive treatment. While surgery can be effective, it's not without risks. Complications reported include hematoma, infection, permanent paresthesia, hyperesthesia, and even permanent muscle impairment in rare cases. Recurrence of symptoms may require revision surgery. These potential complications highlight why non-surgical treatments should be prioritized and why surgery should be reserved for carefully selected patients with confirmed diagnoses. Cases of piriformis syndrome are caused by rare conditions like pyomyositis, endometriosis, lipoma, or even lymphoma. Pyomyositis, an infection of the piriformis muscle, can be life-threatening if not diagnosed early. MRI or CT scans are crucial for rapid identification and treatment. Other rare causes include vascular anomalies, cysts, and calcifications. Recognizing these unusual presentations is important for timely and effective management. Notable finding from the review is that 9% of patients had previously undergone unsuccessful lumbar spine surgery before being diagnosed with piriformis syndrome. Most of these patients experience pain relief after appropriate piriformis syndrome treatment. This underscores the importance of considering piriformis syndrome in patients with persistent sciatica after spine surgery to avoid unnecessary procedures and improve outcomes. It's important to acknowledge the limitations of the available evidence. Most data come from case reports and small series, which can be subject to selection and publication bias. There's also variability in diagnostic protocols and reporting, making it difficult to compare outcomes across studies. Despite these challenges, systematic reviews like this provide valuable insights and help guide clinical practice. Healthcare providers, the key takeaway is to maintain a high index of suspicion for piriformis syndrome in patients with sciatica, especially when imaging doesn't show disc disease or when previous treatments have failed. Use a combination of clinical evaluation, physical examination, and when possible, instrumental tests like MRI or diagnostic injections. Prioritize non-surgical treatments and reserve surgery for well-selected cases with confirmed diagnoses. Piriformis syndrome can significantly impact a patient's quality of life, causing chronic pain, reduced mobility, and limitations in daily activities. Early recognition and effective management are crucial for restoring function and improving well-being. Patients should be encouraged to communicate their symptoms clearly and work closely with their healthcare team to find the most appropriate treatment plan. Looking ahead, more high-quality research is needed to establish standardized diagnostic criteria and treatment protocols for piriformis syndrome. Larger studies and randomized trials could help clarify the best approaches and improve patient outcomes. Advances in imaging and minimally invasive treatments also hold promise for the future management of this complex condition. Wrap up: piriformis syndrome is a challenging but treatable cause of sciatica and lower back pain. Accurate diagnosis relies on a combination of clinical assessment and instrumental tests, with MRI being the most helpful tool. Most patients improve with conservative therapy, but surgery can be effective for selected cases. Awareness of this condition among clinicians and patients alike is key to improving outcomes and quality of life. Thanks for joining us on this comprehensive journey through piriformis syndrome.